Good morning, one and all. Today, it is going to be a discussion on a case scenario, how to approach it. Coming to the case, 24-year-old male who is morbidly obese presented to ER with complaints of high-grade intermittent fever associated with chills and generalized weakness since around 1 week. Patient also complains of 2 episodes of vomiting in the morning, and since then he is complaining of exercise breathlessness, which was present since last few hours. To start with, initially he was taking treatment at home by an registered medical practitioner. As symptoms did not subside and he developed new breathlessness, he was shifted to our hospital. At the time of presentation at ER, the patient is conscious, obeying commands with a heart rate of 154 per minute, respiratory rate of 45 to 50 per minute on room air, with BP of 150 by 100, saturations of 98 to 100% on room air, and he was febrile with a temperature of 101 degree Fahrenheit. On auscultation, heart sounds were heard, respiratory sounds were clear, per abdomen was soft, and bowel sounds were present. Routine blood investigations and ABG sent. ABG as follows: pH of 7.44, PCO2 of 25, PO2 of 93, bicarb of 17, lactate of 1.2, so sodium of 133, potassium 3.0, chloride 108. So the patient was admitted ICU.
అక్షిత్ గారు, సారీ టు డిస్టర్బ్ యూ, ఎందుకంటే నేను ట్రై చేస్తున్నాను. సో పేషెంట్
patient complaints of high-grade fever associated with chills and weakness for 1 week, sir.
1 week, okay. 1 week నుండి హై గ్రేడ్ ఫీవర్ ఉంది.
అవును సార్.
సో హీస్ అండర్ యాంటీబయాటిక్స్ లోకల్ డాక్టర్ దగ్గర.
లోకల్ డాక్టర్ మామూలుగా ఓరల్ టాక్సీ మీద పెట్టారు సార్, అండ్ ఫీవర్ వస్తుందని చెప్పి యాంటీబయాటిక్ డోలో తీసుకుంటున్నాడు సార్, అంతే.
ఫైన్. సో ఎనీ అసోసియేటెడ్ హెడేక్, వామిటింగ్స్ అట్లా ఏమున్నాయా?
అదేం లేదు సార్. టుడే మార్నింగ్ హీ డెవలప్డ్ 2 episodes of vomiting, and since then exertional breathlessness వస్తుందని చెప్పి ER ప్రెజెంట్ అయ్యారు సార్.
ఓకే. సో ఏమైనా కోమార్బిడిటీస్ ఉన్నాయా? 24 years కదా?
24 years, and he is just morbid obese male, around 100 kgs అలా ఉన్నాడు సార్ వెయిట్.
కోల్డ్, కాఫ్
ఏం లేదు సార్.
ఓకే ఫైన్.
వైటల్స్ వచ్చేసరికి టెకికార్డియా 154 హార్ట్ రేట్,
హార్ట్ రేట్
150, రేట్ ఆఫ్ 140 to 50 per minute, saturation 98 to 100% of room air with temperature of 101 degree Fahrenheit.
ఓకే ఓకే ఫైన్. సో ఈసీజీ రిథమ్ ఏంటిదండి
సార్? సైనస్ టాకికార్డియా ఉంది సార్.
ఓకే ఫైన్.
ఆస్కల్టేషన్ వచ్చేసరికి హార్ట్ సౌండ్స్ ప్రెసెంట్, లంగ్స్ క్లియర్, per abdomen was soft and bowel sounds were present.
Okay.
ABG పంపిస్తే pH of 7.44, PCO2 of 25, PO2 of 93, bicarb 17, lactate 1.2, sodium 133, potassium 3, chloride 108.
Fine.
Now, with the above history, what can be our working diagnosis?
Sir, okay.
What investigation?
Sir, first junior start chestara?
Sir. David sir.
Yeah, because this presentation of clinical scenario and the history, what is your working diagnosis, differential diagnosis, and what is the initial treatment and what investigations we will order? Any students can respond. Hello?
Sir, BP అయితే బాగానే ఉంది కదా? BP
150/100 sir.
150/100.
150 హార్ట్ టాకికార్డియా కూడా ఉంది, 150 ఉంది.
154 sir.
154. Respiratory is 40 to 50. Saturation is 98, 99.
Okay.
And is severe breathlessness.
So nobody responded అంటే ఎవరు స్టూడెంట్స్ లేరు అన్నమాట.
సార్ ఇది మోస్ట్లీ వైరల్ కాజ్, మోస్ట్లీ మయోకార్డైటిస్ ఉంటుంది సార్ ఒకటి. ప్లస్ ఎక్స్రే ఎట్లా ఉంది సార్? చేశారు ఏమన్నా?
X-ray was
sir, that's what we are asking. What is the working diagnosis and what investigation?
Clinical presentation.
Clinical presentation clear sir. Clear.
Is he having any burning micturition, abdominal pain or anything?
No sir.
No. So the clinical presentation will be either a cardiac viral myocarditis, possibly viral or any other reason. Mostly looks like viral, or a pneumonia ఉండొచ్చు. ఇవి రెండు సార్ నా వైపు నుంచి. ఆల్ వి నీడ్ టు రూల్ అవుట్ హై గ్రేడ్ ఫీవర్ కాబట్టి మలేరియా, డెంగ్యూ, లెప్టో మిగిలిన అన్ని రూల్ అవుట్ చేసుకోవాలి. ట్రాపికల్ డిసీజెస్.
Sir, what is the initial management?
ఇనిషియల్ మేనేజ్మెంట్ విల్ బి ఎయిర్ వే కి కాన్షియస్ ఫాలోయింగ్ ఉన్నాడు కాబట్టి బ్రీతింగ్ వీ హ్యావ్ టు పుట్ నాన్ ఇన్వేజివ్ వెంటిలేషన్ బికాస్ హిస్ రెస్పిరేటరీ రేట్ ఇస్ హై. వీ నీడ్ టు ప్రిపేర్ ఫర్ ఎమర్జెన్సీ ఇంట్యుబేషన్ ఆల్సో బికాస్ ఈజ్ టకీకార్డిక్ అండ్ టకీప్నిక్. సర్క్యులేషన్ కి ఒక డజన్ నీడ్ ఒకసారి ఎకో కార్డియోగ్రఫీ చేసుకుంటే నాకు కొంచెం ఐడియా వస్తుంది సార్ హౌ ఈస్ ద హార్ట్ కండిషన్ అనేది. ఏమైనా చేయగలుగుతామా సార్?
NIV, sir, or just oxygen mask is sufficient?
Sir?
Is it require NIV or just oxygen mask or NRBM is sufficient?
No, NIV sir, because respiratory rate is high, 40 ఉంది కదా.
And lungs are clear, saturation is 100%.
Still I want to put on NIV. Work of breathing I have to decrease it.
Okay, sir.
We put a working diagnosis of asthma.
Sir, any controversy, Satish sir, Mohan sir? Agree with me.
TRP peripheral smear urine routine sign down.
Fine, ma'am. Just I
Go
put a
further,
working diagnosis of viral or tropical illnesses. Sir.
Go further slides.
Coming to the patient was admitted in ICU. Here are the blood investigation sense. Hemoglobin of 15.2 g%. Total comes 5,300. Platelets of 39,000.
Akshit. What is your differential diagnosis for this patient?
It can be, as you said, sir, it can be any viral illness causing pneumonia, viral pneumonia, super added bacterial. Rule out tropical illnesses.
Okay. Okay. Inka? Sorry, okay, fine. Go on.
Blood pressure, hemoglobin.
And also we suspected pulmonary embolism because morbidly obese patient with exertional dyspnea.
Okay, Anna. And he's a walking patient, కదా?
Walking అంటే came with severe breathlessness.
కాదు అంటే ఈజ్ నాట్ ఫర్ ఫ్రాక్చర్ ఆర్
yeah he is walking only but he is morbidly obese. We don't know underlying background.
Sir, right.
He had a suspicion.
Yes sir.
His peripheral smear showed marked thrombocytopenia with TLC showing leukocytosis of reactive morphology. Smear suggested viral or bacterial infection.
ప్లేట్లెట్స్ ఎంత ఉన్నాయండి?
39,000 sir.
ఎంత?
39,000.
29,000. ఓకే.
39 sir.
మరి అక్కడ ఆర్ఎంపి ముందు బ్లడ్ టెస్ట్లు చేయలేదా దీనికి?
వాళ్ళు ఏమి ఇన్వెస్టిగేషన్స్ అవ్వలేదని చెప్పారు సార్.
ఓకే ఫైన్.
CRP of around 81 and procalcitonin of 4.3. His renal function parameters were normal with mildly deranged LFT showing mild elevated bilirubin and liver enzymes. Transaminitis was present.
ఎంత ఉంది బిలిరూబిన్?
Bilirubin 2.3. Bilirubin of 2.3. Dilute bilirubin of 0.9.
ఇది ఎంజైమ్స్ ఎన్నిసార్లు ఎలివేట్ అయి ఉన్నాయి? SGOT PT?
Sir, 2 to 3 fold sir.
2 to 3 times
అవును. SGOT and SGPT. ALP is normal.
ఓకే సరే ఓకే ఫైన్.
Dengue, QBCMP and strep typhus serology sent all were negative. Viral screening was non-reactive. CU showed 8 to 10 pulses and nothing significant. 2D echo was done. Patient was having tachycardia during study with concentric LVH, dilated LV, global hypokinesia with mild to moderate LV dysfunction. He was he was managed with guarded IV fluid resuscitation followed by maintenance and was put on nasal prongs. Started on IV empirical antibiotic, antacids, IV antipyretics and supportive care. On coming to his general condition still continued to be the same. Now the patient was though conscious was a bit irritable, showing throwing fever spikes of around 102 to 104 degrees high grade intermittent fever with heart rate of 150, respiratory rate of 40 to 46 with SpO2 100 on nasal prongs and his blood pressure was around 160 by 100.
Akshit.
Yes sir.
Hold at the point. So initially at this point we have a diagnosis of thrombocytopenia, hepatic involvement, febrile illness.
Yes sir.
Okay, so mostly we need to look into all the tropical fevers,
Yes, sir.
starting from dengue, leptospirus, scrub typhus, malaria, all these things to be ruled out. So we need to investigate at this point what is the chest X-ray.
Chest X-ray is totally normal, sir.
X-ray was normal,
Yes.
despite his having tachypnea and
Yes,
maintaining
X-ray
good
was,
saturations with minimal oxygen support.
X-ray was clear, and on auscultation also vesicular breath sounds were heard, no added sounds.
So what antibiotics you have started now?
We started him on meropenem, sir.
Why meropenem?
Because we don't know what he has come from community and he's been on oral antibiotics since 1 week with high grade fever and even myocarditis was present, deranged LFTs.
Okay. So see, we have to consider these diagnoses like dengue fever, one possibility.
Yes, sir.
With multi-organ involvement. So for which don't require any antibiotic, we require only fluid resuscitation.
Yes, sir.
Second possibility is scrub typhus. Though
Yes,
test
sir.
is negative early can be negative. We need to wait for 5 days to get the test positive. So we need to cover scrub typhus with the doxycycline.
Yes, sir.
The third possibility is leptospirosis. We need to cover with the cephalosporin.
Yes, sir.
Or beyond that, maybe meropenem may be considered at that point, but still it is a high kill for that patient.
Yes.
The fourth one is we need to also cover malaria. So because that's one of the technical issues where we have to look into, but it's a controversy without having a positive smear, malaria need not be treated is one guideline says.
Yes, sir.
Okay, so that is a controversy. Rather, I would again start this patient all the 4 antibiotics like doxycycline, cephalosporin, plus or meropenem with Falsigo. Anyway, doxy will cover for the complicated malaria. So this should be the line of antibiotic coverage, and we need to further evaluate. Maybe chest X-ray may not be sufficient at this point. We need to look into the CT chest, HRCT chest. And what, sir?
We put him on meropenem and doxy only, sir.
Okay.
సార్ ఇది మనకు
జక్కిన ఒక మాట, అందరూ వైరల్ అన్నారు కదా, మరి యాంటీవైరల్స్ ఎందుకు వాళ్ళు ఆలోచించట్లేదు?
We don't have a specific viral therapies except for H1N1 and COVID, sir.
HSV.
That's
కానీ it can't be like
so for
సారీ సార్, జస్ట్ ఏంటంటే మీరు 5 days అన్నారు కదా సార్, యాక్చువల్ గా ఫీవర్ 1 week నుంచి ఉంది. అండ్ ఐ థింక్ ఎంపరిక్ యాంటీబయోటిక్ మెరోపినం, ఐ అగ్రీ విత్ దిస్ పేషెంట్. ఎందుకంటే ఐఎమ్ సీయింగ్ మోస్ట్ ఆఫ్ ద small clinics, what they do, they are giving antibiotics, sir. BLA కాంబినేషన్ లో ఇన్ఫ్యూజన్స్ ఇచ్చి పొద్దున సాయంత్రం ఇచ్చేసి చూస్తున్నారు. సో I think that is one of the place where these are nidus of infection, MDR also, because a lot of people come and chemotherapy people also will come and take chemotherapy drugs, antibiotics ivanni. We are seeing some patients having multi-drug resistant organisms.
Sorry, sir. So continue, Ashit. Thank you.
Coming to day 2, all the parameters were same. Patient was, though conscious, he was irritable. Repeat blood investigation showed patient is going towards pancytopenia. His HP has come down 15 to 13. Total comes from 5,000 to 3,700. Platelets had further dropped to 16,000. And liver enzymes showed a mild increase. SGPT has increased to 159, SGOT to 437.
More febrile, 104 temperature.
And his CRP has increased to 84, and LDH was 2,680. Ultrasound abdomen was done, which showed hepatosplenomegaly with diffuse intestinal wall thickening in right iliac fossa. So as suggested by radiologist,
peripheral smear etla undandi?
Peripheral smear showed marked thrombocytopenia and leukopenia, sir.
Any cystocytes ఉన్నాయా?
ఏం లేవు సార్.
సో బేసికలీ లింఫాయిడ్ ఆర్గన్స్ కూడా ఎన్లార్జ్ ఉన్నాయి. ఎనీ లింఫ్ నోడ్స్ పాల్పబుల్?
పాల్పబుల్ లింఫ్ నోడ్స్ ఆర్ ప్రెజెంట్ సార్.
ఎక్కడ?
బట్ అంటే వెన్ సీన్ ఇన్ అల్ట్రాసౌండ్ అప్పుడు అంటే సిఈసిటీ చేసినప్పుడు మెసెంట్రిక్ లింఫ్ నోడ్స్, ఇంగ్వైనల్ లింఫ్ నోడ్స్ కొంచెం ఎన్లార్జ్మెంట్ ఉన్నాయని చెప్పారు సార్.
ఓకే. సో హెపటోస్ప్లీనోమెగాలి అయితే ఉంది అంతేనా?
Splenomegaly ఉంది sir. And right iliac fossa దగ్గర ఉన్న cecal wall, ascending colon, terminal ileum all showed thickening.
Now these platelets are low, thrombocytopenia and also leukopenia.
Yes sir.
Now do you see any gain platelets?
ఇప్పుడైతే జాయింట్ ప్లేటెట్స్ లేవు సార్.
Clear లో లేవు. So there might be a production problem, but also WBC also is breaking because LDH is very high.
Yes sir.
Ferritin ఎంత ఉందండి చెక్ చేశారా?
ఫెరిటిన్ డే 3 పంపించాం సార్.
ఎంత ఉంది?
డే 2 లో ఉన్నాం. 14,000 ఉంది సార్.
14,000. Okay,
So
fine.
with this we proceeded.
HB ఎంత ఉంది?
HB 15 నుంచి 13 కి వచ్చింది సార్.
హెమటోక్రిట్ ఎంత ఉంది?
Hematocrit was something around 47 ma'am.
సార్ ఇది కూమ్స్ టెస్ట్ ఏమైనా చేశారా డైరెక్ట్ ఇండైరెక్ట్?
లేదు సార్, చేయలేదు.
So I would like to investigate into these things like the hemolysis అవుతుంది
Yes
and
sir.
also thrombocytopenia ఉన్నాయి కాబట్టి I like to do a Coombs test.
Okay.
Okay, direct indirect. తర్వాత ఇది doesn't look like a HUS or TTP లాగా ఫిట్ అవ్వట్లేదు ఈ పేషెంట్, ఎందుకంటే ఆర్టర్ స్పిటోరియం లేదు,
True sir.
HUS TTP బట్ LDH is elevated, ఈవెన్ అనీమియా లేదు ఒకటి.
ఫాల్ అయితే స్టార్ట్ అయింది సార్. 15 నుంచి 13 కి వచ్చింది.
అంటే ప్రెజెంటేషన్ అట్లా లేదు,
ప్రెజెంటేషన్
ఆల్సో ప్రెజెంటేషన్ అట్లా లేదు కదా HUS TTP లాగా లేదు. But LDH is very high means that says that there is a hemolysis going on.
Yes sir, hemolysis is happening.
If all are then would like to go with a connective tissue disorders or ANA chasesi, would like to directly go for a bone marrow because splenomegaly is there, so it can turn into a ALL లాగా ఏమన్నా ఉండొచ్చు అని.
సార్ HLS సిండ్రోమ్ ఒకటి కన్సిడర్ చేయాలి సార్.
Yes definitely ఫిట్ అవుతున్నా సార్ క్రైటీరియా.
Go next slide.
We decided to transfuse 1 point of SDP and proceeded with bone marrow biopsy.
And sir bleeding ఉండేనా?
Bleeding manifestation ఏం లేవు సార్.
Okay.
So now at this point of so with the above reports and with the above laboratory and radiological reports, any further change in diagnosis? As Satish has said, I would even consider HLH in this case. Okay. So for the additional investigations, we sent triglycerides, we sent ferritin levels, fibrinogen levels and all. Coming to we put a HS score for this patient. As it was one of the known scoring system of HLH, the patient was not on any immunosuppression. The positive factors in this patient was he was having a temperature high grade of around 101 with 2 organs, hepatomegaly, splenomegaly, and cytopenias were present. On day 3, his urine cultures showed no growth, ferritin of around 14,700, triglycerides around 290 mg per deciliter, and fibrinogen of 1.4. It has come down. Bone marrow aspiration suggestive of marrow suppression with scattered small hemolymphophagocytic macrophages identified. Am I audible? Hello?
Yeah. Go ahead.
Bone marrow biopsy shows thick bony trabecular from bony cortex mixed with blood clots and a cluster of hemopoietic precursors. So we put a provisional diagnosis of as this was fitting into the diagnostic criteria of HLS 2004. As he is an adult patient, we did not send any molecular diagnosis because of cost entry. And the diagnostic criteria he met with, we should meet any 5 out of 5. He had fever, he had organomegaly, he had cytopenias, he was having hypertriglyceridemia, hypofibrinogemia, hemophagocytis on blood smear, high ferritin levels. So we proceeded putting our provisional diagnosis HLH secondary to sepsis with MODS. So we gave cross consultation to hematologist as his The general condition was deteriorating. He developed new onset of confusion. He was becoming delirious. On from the last 2 to 3 days, he was having severe tachycardia, tachypnea with LV dysfunction and all. So, as per hematologist's advice, we started him on IVIG, if for 1 mg per kg per day, and continue the rest medications. On day 4, the patient became slightly better. His heart rate has.
Here one question, Akshit.
Yes, sir.
If a cost constraint is there, can you go ahead for steroids?
Even in many cases, steroid has been tried, sir. But we gave both the options of steroid and IVIG. They said, for 2 doses, we will try to afford it, and they afforded it, sir.
Jakina?
Even sepsis, hematologist said it is better to try IVIG over steroid in this case, actually.
Yeah, what about other people's opinion? Jakina, Satish, Mohan sir, Rani madam. Hello?
IVIG ఎన్ని డేస్ ఇవ్వాలి? 5
2 days, ma'am.
No, actual treatment wise, అంటే he could afford 2, but was the suggested treatment 5 or how many?
2 to 3 days అని చెప్పాను.
2 to 3 days is sufficient, madam.
Okay.
Sir, dose, sir.
Actually, 0.5 to 1.5.
IVIG ఎందుకు?
Sir, అంటే you can give IVIG in 2 days or 5 days, sir. 2 days ఇస్తే కనుక the dose will be అది రెగ్యులర్ అయితే 400 mics per kg. అదే కనుక 5 days, or you can give 1 mg per kg per day. So అట్లా అయితే 2 doses. So same 5 doses can be given in 2 days.
Yes, sir.
Jakina, why don't you go for steroid?
Steroids, not sure, sir.
Any contraindication in this case?
ఇన్కి ఆల్రెడీ ఇది ఎక్కువ ఉంది కదా, PCT, CRP ఇవన్నీ ఉన్నాయి కదా. సూపర్ ఇన్ఫెక్షన్ కూడా ఉందా?
అది ఇన్ఫ్లమేషన్ మార్కర్ కదా మేడం. సో ఇన్ఫ్లమేషన్ ఉన్నప్పుడు ఉంటుంది కదా మేడం.
ఏమో, యూ డోంట్ నో. మల్టీ ఆర్గన్ ఫెయిల్యూర్ కు వెళ్తున్నాడు అంటున్నారు కదా. సో ఇస్ ఇట్ జస్ట్ బికాస్ ఆఫ్ ఇన్ఫ్లమేషన్ ఆర్ ఇన్ఫెక్షన్? సెప్సిస్ లో ఉంటే యూ గివ్ హై డోస్ స్టెరాయిడ్స్.
Definitely, it is a infection going to very high inflammatory syndrome. That's why we are afraid of giving the steroids.
That's why
steroids we opted for IVIG because of, as you said, the progesterone levels are high and high grade fever.
Sir, ఇది ఎన్నో రోజు సార్ డయాగ్నోసిస్ మీకు వచ్చిన తర్వాత?
మాకు వచ్చిన తర్వాత సెకండ్ డే.
What are your cultures, sir? Cultures
present 3rd day అయితే no growth, sir. Urine culture no growth. The blood culture so far no growth.
Okay, go further.
Okay.
Hello. Combination of dexamethasone and etoposide is one of the described treatment kada?
Sir, అది మనం I will describe in future, sir.
Sir.
Next slides will come, sir.
Coming to his, after giving first dose of IVIG, his platelets have improved from 16 to 49,000. Now the peripherals showed reactive lymphocytes with occasional giant platelet, and his liver enzymes, which were deranging, had a halt with procalcitonin of around 11. So we continued with the second dose IVIG. His general condition gradually became better. Confusion and irritability has come down after 2 doses, and his tachycardia, tachypnea has all come down. Even his LV dysfunction started settling. And now on the day 5, his blood cultures grew Salmonella typhi. Both brachial, right brachial and left femoral culture, aerobic cultures grew Salmonella typhi. On day 7, he was shifted to room, and on day 10, he was discharged. Coming to the discussion, this was a case of hemophagocytic lymphohistiocytosis. What is histocytosis? It is a large white blood cell residence in tissues, including Langerhans cells, monocytes, macrophages, dermal, interstitial, and dendritic cells. Usually.
So, Akshit, ఇది సాల్మోనెల్లా వలన it is has triggered?
Yes, sir. Yes, sir. Salmonella has triggered his him and he landed into HLH. Okay. Coming to HLH, it comes into the group of macrophage-related histiocytic disorder. Histiocytic disorder of two types. Now we are dealing with a macrophage-related histiocytic disorder. So coming to a definition, it is a condition involving sustained immune or inflammatory reaction leading to cytokine storm because of ineffective immune process. So HLH is also known as cytokine storm syndrome or macrophage activating syndrome or hemophagocytic syndrome. Here, hemophagocytes can be seen engulfing the host blood cells by macrophages characterized by presence of RBCs, WBC platelets, or the fragments within the cytoplasm of macrophages. Commonly seen in all age groups, mostly seen among infants, children, and adults. It occurs as either familiar or sporadic and disrupts the host immune hemostasis. These are of two types, primary and secondary. Primary is usually familial, presence during infancy or early childhood, and it is due to autosomal recessive gene inheritance, usually characterized by gene mutation either at one or the of the FLH loci or gene responsible for one of the severe immunodeficiency syndromes. It is fatal, but when treated has a good prognosis. Coming to secondary HLH, it is usually sporadic nature and is because of infection related associated or can be because of malignancies or can be because of rheumatological disorders underlying. If you identify a clear trigger, then treat accordingly. The patient chances of recovery are good. Coming to this HLH, it was first diagnosed in 1991. Histocyte Society has put forward a diagnostic criteria which was later modified by Hunter et al. In 2004. Coming to the etiology, primary is usually congenital and follows Mendelian's laws of inheritance and is because of genetic defects of PFR familial genes and can be associated with immune deficiencies associated with albinism like Grisely syndrome and other immunodeficiencies like X-linked lymphoproliferative disorder type 1, type 2 and all. Secondary or acquired secondary HLH is because of either acquired or sporadic nature and is mostly seen commonly in patients with infections which can be due to viral as Epstein-Barr virus, CMV, HIV, parvovirus, HSV, coronavirus. Also, there are few case reports in which patients presenting with COVID-19 has gone into cytokine storm second and landed into HLH and have finally succumbed. Even H1N, there are rare cases in which even H1N1 and even hepatitis like HIV, HBsAg, HCV has also landed into HLH. Coming to bacterial infections, we usually see this with tuberculosis, enteric fever, and any sepsis can even trigger this. Fungal infections most commonly associated with HLH are Candida. Parasitic infections like malaria, dengue, leishmaniasis can also cause HLH. Next, coming to malignancies, mostly lymphomas and leukemias cause HLH. Macrophage activating syndrome is usually seen in patients of autoinflammatory and immune disorders. Here are a few conditions. HLH associated with rheumatological conditions as in SLE, adult onset stage disease, juvenile rheumatoid arthritis, and less often seen with Kawasaki's disease. Next, HLH can occur due to immune activating therapies or because of drug hypersensitivity. And patients who are having taking lamotrigine also can trigger this. And can also be seen in patients who underwent transplantation, hematopoietic stem cell transplantation, and who have trauma, and patients who have taken immune suppression iatrogenically or because of vaccination can occur in few cases post-op. Patients on hemodialysis. Rarely, even a few cases have been reported in pregnant women too. Coming to pathophysiology. Usually, when there is an infection or an autoimmune condition or a cancer, the CD8 cells get activated and cause in release of interferons, because of which there occurs cytolysis, and thus the nidus which has caused this helps are removed or terminated because of immune response, and the rest are inactivated and stored as memory cells. But in HLH, These activated cells release interferons along with interleukins, tumor necrosis factor, and which causes tissue infiltration and organ destruction, thus causing MODS. Cells involved in this HLH are macrophages, natural killer cells, and cytotoxic lymphocytes. This is an picture extracted from Stinger article, in which it is shown that HLH is secondary to hyperinflammatory condition causing cytokine storm, can occur because of massive release of cytokines and hypersecretion of interleukins, tumor necrosis factor, thus causing phagocytosis of bone marrow, hematopoietic cells, and reticular endothelial cells in other organs. Systemic manifestations of this cytokine storm can present with unremitting fever, lymphadenopathy, hepatosplenomegaly, multi-organ failure, hyperferritinemia. Coming to the clinical features, patient usually presents as febrile illness associated with multi-organ involvement. Initially, these patients may mimic infection or fever of unknown origin, hepatitis, and if it's CNS involvement, patient may be diagnosed as encephalitis. The patient may require prolonged hospitalization, and many patients succumb to death without proper clinical diagnosis. Coming to the common findings, we see fever, cytopenias, abnormal liver function tests, hepatosplenomegaly, rash, neurological symptoms, high ferritin levels. Hemophagocytosis on either tissue or bone marrow biopsies is neither sensitive nor specific for hemophagocytic lymphohistiocytosis, because they can also be seen in patients post-surgery, post-IVIG, or transfusion reactions too. And based on this ferritin levels, there is a study called SECIT study, in which it showed that high ferritin levels show correlation with that of the diagnosis of HLH. They state that ferritin levels of around 10,000 and around 20,000 shows around 90% association with HLH, and if it is greater than 30,000, it is possibly HLH. What are the mechanisms which are involved for this elevated ferritin levels? It is because of passive release of interleukins due to cell damage, passive release during the cell damage, increased secretion by macrophages which are released during erythrophagocytosis, increased ferritin gene expression by TNF alpha, and decreased clearance due to glycosylation. Even the serum ferritin values have additional prognostic value in septic patients. There are few markers of cytokine storm like CD25, which are produced from activated T cells, and CD163, which are produced from activated macrophages. The combination may be useful in diagnosis and follow-up to assess activity, but not available everywhere. NK cell functions is usually time-consuming and can only be done in specialized labs. Coming to the spectrum of this in severe inflammatory syndrome, it may range where it has a wide range from pediatric HLH to adult HLH to immune-associated syndrome to macrophage activation syndrome to malignancy-associated hemophagocytic syndrome. This was a diagnostic criteria which was put forward in a recent article, in which he put a diagnostic, he took into consideration HLH 2004 criteria and other common clinical symptom, lab abnormalities, and histological features, in which he says clinical symptoms of hepatomegaly, lymphadenopathy, liver dysfunction, bleeding, edema, rash, CNS dysfunction, multi-organ failures are the clinical symptoms. Histological features include a tissue infiltration of activated immune cells and DIC. Lab abnormalities like hypercytokinemia, leukopenia, hypoproteinemia, hypoalbuminemia, hyponatremia, hyperbilirubinemia, elevated D dimers, elevated liver enzymes, elevated LDH, reduced T cell cytotoxicity, and soluble CD163. Roughly in the year of 2004 HLH criteria considers laboratory any 5 of 8, but of the 8 we have hemophagocytes and NK cell activity and soluble CD25, which are not available everywhere and are very possible or very impossible or difficult to obtain. So in 2019 they put forward and modified HLH criteria, which takes into consideration and clinical symptoms like fever, splenomegaly, cytopenias, hepatitis with any one of the following, like solubles or solubles, elevated CD25, hemophagocytes or low NK cell activity, and supportive features like hypofibrinogenemia, hyponatremia, hypertriglyceridemia. So coming to the diagnostic workup, coming to the history and physical examination, we should ask for the family history and the duration of the fever, any organomegaly is present, any recent infections, is the patient in known case of malignancy, rheumatological disorder, or he is taking any immunosuppression, anything. If there is any clinical suspicion of HLH, then laboratory investigations include complete blood picture, next liver function tests, ferritin, fibrinogen, triglycerides, and LDH, albumin, all this sufficient. If the lab work is consistent with HLH, if the patient is a young, like infant or child, we can even plan of, we have to proceed with bone marrow biopsy. And in case of children, we can look for familial genes if present any. If it is adults, we have to consider for infections, malignancy, or underlying rheumatological disorder. Based on that, treat accordingly. Example, if it is a known case of rheumatological disorder, continue immunosuppression, steroid, and disease-specific treatment. If it is a known case of malignancy, steroid with etoposide. If infections, antimicrobials. As per HLH 94 protocol, which I'll be discussing. If there is relapse or refractory disease, consider stem cell transplant. Coming to the treatment, HLH is usually triggered because of infection. If it is infection, consider antibiotics, immunosuppressive therapy, and if required, IVIG. If the patient is been started on immunosuppressive therapy, we can consider steroids, etoposide, cyclosporin. We can give it for around 8 weeks in primary and followed by bone marrow transplant. If it is secondary, look for other underlying cause. If any present, treat it. If it is because of hematological macrophage activation symptoms seen in rheumatological disorders, continue maintenance immunotherapy. If the patient has having neurological dysfunction, you can even consider giving intrathecal steroid and methotrexate. So this is a nutshell of treatment. We start the patients in corticosteroids. If needed, IVIG. For immune suppression, we can use anacrina, which is an IL-1 receptor antagonist, and we use tocilizumab, which we frequently use in COVID. It's an IL-6 receptor antagonist, and etoposide in cases of malignancies, which is an topoisomerase 2 inhibitor. And accordingly, rituximab have been also given, tried in few cases. Now, in a study known as HIT HLH trial, which is undergoing research, where antithymocyte globulin along with etoposide is being tried. Coming to stem cell transplant, usually this is done in patients who are patients who are clinically stable, can be treated for the triggering condition, or can be continued to search for it. Patients with hematopoietic cell transplant are usually treated with HLH 1994 protocol or HLH 2004 protocol. Both are almost the same, in which they consider giving steroid along with immunosuppressants like cyclosporin and all. But the only advantage of 2004 or 1994 is the treatment duration has been reduced from 54 weeks to 40 weeks. But the disadvantage with 2004 protocol is, even though it has been decreased, we have not shown any mortality benefit. Coming to poor prognostic indicators of the patients who have undergone stem cell transplant, if the patient is of a young age, if he is having shock, if he is having thrombocytopenia, and failure to induce or failure of the some therapy to induce remission prior to stem cell transplant. So it can be considered in patients who have HLH gene mutation, who are having refractory disease, who are having CNS involvement, and hematological malignancy not cured by chemotherapy. Even one of the major difference between 1994 protocol is, after induction, they can either go with maintenance or hematopoietic stem cell transplant, which was in 2004 was modified as induction phase followed by stem cell transplant therapy along with maintenance therapy. But there was no benefit. So it is a choice of individual physician to either proceed ahead with 1994 or 2004 protocol. This is in nutshell about the target directed therapy. Patient of HLH identify, If the patient is having any genetic factors, treat accordingly. If it is because of infection related and if it is because of viruses, start them on antivirals. If it is because of bacterial infection, start antibiotics. If it is because of parasitic infections or fungal, start their respective agents. If it is a known case of malignancy, we can consider etoposide along with steroid and later followed by stem cell transplantation. Few cases even have been tried with CHOP regimen, but not much of benefit. Autoimmune conditions have been tried with high dose prednisolone and interleukin 1 receptor antagonists like anacrina. And if insufficient involvement or CNS, then etoposide can be added. If it is because of drug induced, then can try tocilizumab and may consider etoposide. And rest of the cases can consider IVIG. Coming to the differential diagnosis, coming to the differential diagnosis, the patient may have a general infection which can be overtreated as HLH. The patient can be only treated as H because of HLH is a very rare perspective in here. We can treat them only as hepatitis or encephalitis, a common infection of fever of unknown origin or some liver disease, and patient, especially culture negative septic shock patients and catastrophic antiphospholipid syndrome, drug rash, eosinophilia, and systemic symptoms. These are a few manuscripts of typhoid fever complicating with HLH, dengue associated with HLH, HLH seen in COVID-19 pandemic, HLH later added into the spectrum of immune cytokine-driven immune disorders. This is how dengue-associated hemophagocytic lymphocytosis happens. Coming to diagnostic tools, there are many tools like HLH 2004 diagnostic criteria, HS score, MH score, juvenile JIS, A bar, macrophage activation syndrome. But more commonly, we use HLH and HS score to diagnose. To summarize, in the history, we should ask for any prolonged fever, organomegaly, multi-organ failure, hepatitis, encephalitis. If present, and then look for cytopenias and elevated level of ferritin. Rule out active HLH by doing CBC, coagulation marker, fibrinogen, triglycerides, bilirubin, transaminase, ferritin, bone marrow. If needed, CNS and imaging studies. If there is no HLH, repeat workup to rule out progression or to active HLH. If present, if there is it needs further investigation, if the patient is a child, can consider genetic morphology. If is an adult, look for natural killer cell activity and the rest of the gene markers. Consider in HLH in patients who have malignancy, who are having infections, rheumatological disease, or metabolic disease. Coming to the take-home points, it should HLH should be considered as a DD in patients who have pancytopenia, fever of unknown origin, who have organomegaly, febrile illness associated with multi-organ involvement. Coming to diagnostic criteria of HLH, we have seen the HLH 2004 criteria, which was later modified in 2009. By either of them can be used. Coming to the whole scoring system, HS score is the most commonly used scoring system. Ferritin levels have a very high amount of clinical significance when coming to, and they have even show good amount of prognostication to initial ferritin of above greater than 10,000, and once treatment have been started, if they continue to decline, it shows that the patient is having a good prognosis. This is usually a condition which is commonly missed or diagnosed lately and carries high mortality. HLH in adults carries high mortality when compared with children, and adults HLH needs more of research, as the present guidelines which we are following for the treatment of adult HLH are all designed based on pediatric studies only. This is one of a one pager in which all the HLS criteria have been put in like a nutshell. Thank you. Any questions?
Thank you, Akshit. Very nice presentation and explained all the criteria and the scoring system and differential diagnosis and treatment protocols. Here in this case, some of our consultants also they told that they are unnecessarily doing the bone marrow biopsy in a very low platelet count. It is simple infection. They can try on continuing antibiotic instead of doing the biopsy, bone marrow biopsy, and IVIG, all these things. But still, we didn't bother, and we want to prove that our suspicion of HLS is correct. We did a bone marrow biopsy. The diagnostic, even though we fulfill all the 5 criteria out of 8, but still we want to prove that it is HLS. So the diagnostic criteria of hemophagocytosis in bone marrow. So the diagnostic feature is you will see the RBC or lymphocytes, neutrophils in the cytoplasm of macrophages. That is the diagnostic bone marrow picture. This is 80 to 90% of sensitivity specificity is there for diagnosis. So it is proved that it is HLH. So any patient having more than 1 week of fever, either whatever it is, dengue treated and fever subsides and patient is improving suddenly. In one case, patient is having high grade fever and further worsening of thrombocytopenia and going into multi-organ. Definitely, we have to consider HLH and go accordingly. So it is a very important case. Sometimes we will consider it as a pyrexia of unknown origin, and we will change the antibiotics, keep on changing antibiotics without going into diagnosis. That may increase the mortality. Any questions? Hello? Hello?
చెప్పండి సార్.
Questions, sir, questions.
David,
సార్ అంత బాగా ఎక్స్ప్లెయిన్ చేశారు. క్వశ్చన్ ఏంటి? ఆ స్లైడ్స్ పంపించు అక్షిత్. దీంట్లో
hello.
Madam. Madam,
Hello?
అడగండి. Yes.
Ma'am, you're audible, ma'am.
Hello, madam.
Yeah, David, actually, when did you suspect? Is it just thrombocytopenia, or when you've seen hepatosplenomegaly, LDH going up? Is it that's when you suspected, or actually when did you suspect HLH for this patient and
Akshit.
decided to do bone marrow?
Yeah. Akshit?
Ma'am, on the day 2, after seeing the raised LDH and further fall of thrombocytopenia, platelets falling further down, and he's shifting towards leukopenia, we put this diagnosis. Actually, we had a similar case something around 9 months to 1 year back, in which he was a known case of around, he was a case of fever of unknown origin for 2 months. Later diagnosed as lymphoma and succumbed before initiating treatment. So as we lost that case, in this case we just jumped ahead and started investigating in signs of HLS after seeing LDH, leukopenia, organomegalies, all that.
Second day we suspected, madam. And third day we did bone marrow biopsy and started treatment on third day.
థర్డ్ డే అంటే ఆన్సెట్ తర్వాత 10 days అన్నట్లు కదా, 1 week నుండి నాట్ వెల్.
Ante.
ఓకే, థ్యాంక్ యూ.
Hello?
Any peripheral smear findings are there, sir? Any peripheral smear findings, sir?
Yeah, peripheral smear.
Peripheral smear lo only maybe giant cells like hemophagocytes, even on bone marrow or tissue biopsy is also not very specific of hemophagocytic lymphohistiocytosis. In the actually 2004 guideline lo chapter gani recent modification lo avi teesesaru sir actually. వర్కప్ అన్నింటిలో ఎందుకంటే టు కమ్ ఇన్ టు బోన్ మ్యారో ఆఫ్ స్మియర్ ఇట్ టేక్స్ లాంగ్ కోర్స్. సో అది స్మియర్ లోకి వచ్చేసరికి పేషెంట్ ని సక్కం అని చెప్పి అది డయాగ్నోస్టిక్ క్రైటీరియాలో పెట్టుకుంటే వీఆర్ గోయింగ్ ఇన్ రాంగ్ వే అని చెప్పి యాక్చువల్లీ దాన్ని సపోర్టివ్ ఫీచర్స్ లో చేసేస్తారు.
Only thing is, it can be a screen. Sometimes pathologists they will warn us to better to go early bone marrow like that.
Yes, sir. The first day itself we will order for complete hemogram. So they will look into the peripheral smear for toxic granulations, band forms, and abnormal cells. Then accordingly they will go further investigation. They will also call the clinician and ask, sir, so and so cells are there. Can we do this bone marrow to for further diagnostic workup? So this is very helpful, definitely.
Actually, what they say is, if the patient has fever with organomegaly, cytopenia, transaminase, with any one of the following, like elevated ferritin or hemophagocytes on biopsy, or low and natural killer cell activity, or elevated soluble CD25, any one is enough of 4 to diagnose it as HLH.
Okay. What is the steroid you started in this case?
Did not give steroids.
You started. Actually, I didn't join in the beginning. That's
started on IVIG.
IVIG directly. Okay.
As his procalcitonin on the initial days was higher, we tried him on IVIG.
Blood culture growing Salmonella typhi in both sets.
Okay, sir.
Actually, the most triggering factor is a virus. Virus had a tendency for immunomodulation, like COVID, severe inflammatory cytokine storm is there. So when patient is having any underlying rheumatological diseases or malignancy, or even though patient doesn't have any comorbidities, patient itself, this patient doesn't have any background, any history except morbid obese. So this patient is like in COVID, some patients are having cytokine storm and multi-organ severe ARDS and died. Like that, patient itself is a what you call genetical predisposition is there. We don't know which patient having this inflammatory syndrome. So for simple typhoid fever, he's gone into HLH, and we don't suspect also. But unless otherwise patient is having this type of worsening scenario, then only we will go through. But which patient is having this this type of going? We cannot predict also. That is the problem with these patients. Anna, Satish.
So Mohan sir was asking about why don't we start some antiviral, the first initial part of our discussion.
Thank you, sir.
One point is, sir, I would first day respiratory symptoms undi, low platelet unte, I would tempt to give Tamiflu for this patient, oseltamivir, suspecting H1N1 in this patient, because that comes in one of the differential diagnosis of this presentation.
Yes, sir, agreed. Even in the few reports they have mentioned it, sir. One case with H1N1 landing into HLH, on the day one they started Tamiflu empirically because of presence of GGS on the HRCT.
So
definitely, Anas, we can no harm in starting Tamiflu also.
Yeah, that's
but why we didn't start? Huh?
No, that's what sir asking about. Why didn't we start antiviral? And maybe at that point, I would definitely go with considering H1N1 also one of the differential diagnosis, because the respiratory symptoms are predominant in this patient with thrombocytopenia. So it comes under one of the viral infection. So the available antiviral to cover H1N1 I would use.
Sir, even if a patient presents predominantly with CNS symptoms, a few cases have been treated with acyclovir 2 for HSV.
Then, sir, if it is like a community acquired meningitis, suspicion is meningitis, it can be pyogenic, it can be encephalitis also. At that point of time, monos of 2 grams plus acyclovir is the mainstay of treatment in Indian scenario in a community acquired meningitis.
Actually, this patient having fever, high grade fever since 1 week, more than 1 week on antibiotics, and lungs are very clear. Even we did a CT abdomen, CCT abdomen along with the screening, CT chest screening, but it's absolutely clear, CT chest.
Okay.
So that is the reason why we didn't start
Antivirals for this case.
antivirals.
Okay. Sure.
Actually, there is no harm, as you said, there is no harm in starting the Tamiflu while suspecting the H1N1, H3 and 2 scenario, but we didn't start due to this.
Sir, good morning, sir. David, sir, and Dr. Naresh. Sir, the discharge.
Hello?
Actually, immunosuppressant 7 పెట్టామా and the next discharge summary లో సార్ మెడికేషన్ సార్ ఈ కేస్ కి
ఇమ్యునోసప్రెసెంట్స్
అవును సార్ ఏమైనా అంటే రికరెన్స్ ఎలా ఉంటుంది సార్ ఇన్ కేస్ మళ్ళీ సాల్మోనెల్లాలో ఏమైనా ఇన్ఫెక్ట్ అయితే మళ్ళీ రికరెన్స్ ఛాన్సెస్
we advised the patient to meet a hematologist for further workup.
Okay, sir.
Usually recurrence because secondary low recurrence radam annadi chala rare because this is triggered mostly because of infection.
Okay.
But primary itlaithe refractory or relapse diseases ki they consider giving immunosuppression along with etoposide actually. Secondaries lo usually it is a field which needs lot of research. Secondary because of infections ippudu varaku eppudu there are no points favoring empiric immunosuppression అదైతే ఎక్కడ డేటా లేదు.
అంటే సాల్మోనెల్లా టైప్స్ మనకి ఫ్రీక్వెంట్ గా వచ్చే ఇన్ఫెక్షన్స్ కదా.
So in all the papers it was given that this is a region which needs lot of further scope of research as there are no strict guidelines what has to be followed.
Okay, thank you.
Yeah, it's a valid question because we cannot avoid the infections in any patient. No, in Indian scenario, if new bout of infection comes maybe after 6 months or 10 or 1 year, so he's a high preponderance to go into another HLA with that infection.
Yes, true sir.
So that's a very tricky area. What is to be done? Still, it is not come into the any guideline or any suggestions.
Even we asked the hematologist also. He was like, we too don't have a proper guideline. We just asked him to come on OP basis for review for the initial few years. That's it, what he said.
So it should be in a past medical history that he once had a HLA. So new treatment should suspect always HLH.
That's it.
Yeah.
We advised him to reduce the weight because we are all seeing the morbid, even young morbid patients having lot of problems. They are very highly vulnerable patients for any infection. We have seen in so many dengue patients, young, even 20 years young, and even obesity patients particularly, even non-obesity also, but there is some genetical predisposition is there. We could not identify which patient is going into this storm.
Yeah.
What we maximum did, we approached the hematologist follow-up and advised to reduce the weight.
Good.
Thanks, Anna. Thank you all for your active participation. Thank you very much. Alage sir, alage. Thank you, Akshit, for a nice presentation, and we collected all the information regarding HLS and made simplified. Thank you all the participants for your active participation. Thank you.
Thank you.
Thank you, Akshit, David.
Thank you, madam. Thank you all.